let's see the questions. Okay, so first question is a 72-year-old man. I'll just start the point. So first question we are seeing, let me just check my feed also. It's just waiting for my device. One second, okay. Okay, so let's start. Okay, so now we are having a look at the first question. So 70-year-old male man. Okay, so let's start. Okay, he developed ADL of 80 beats per minute, and there's a third degree AV block. So now what happens in third degree AV block? The ventricles generate their own pacemaker. So they generate their own pacemaker, and the rate of the ventricular rate is now going to be changed. Okay. So let me just paste it here. Just a second. So in first degree block, there is what? There is a slowing of the rate of impulse which are coming. And in the second degree, what happens? There is a drop in the beats. Okay. So second degree, the beats are being dropped. And third degree, there is no relationship between the two. So the atrial beat is SA node, and the ventricular beats is your ventricular beat, which is developed mainly by bundle of His. So what is happening here is the bundle of His become the new pacemaker in that scenario. Okay. So let me show you the ECG also for that. So let's see the ECG. This is the ECG of complete heart block, third degree. So what you see in third degree is the QRS are coming at their regular interval, okay, and that is around 37 to 40 heart rate, around 40 per minute, around 40 per minute. Whereas the atrial rate, the P waves, they are coming very regularly at a rate of around 80 per minute. So this is what a complete heart block is. So this is a complete heart block. Okay. So question is, in complete heart block, the atria have the SA node rhythm of 80 per minute, and the ventricles get a rate of, yes, bundle of is the new pacemaker, bundle of is, and that is 40 per minute. So we are having 80 per minute and the 40 per minute as the rates. Okay. So let's see the options. Okay. So option number 1, there is one P wave for each QRS. No, there are multiple P waves and less QR. So this is a wrong statement. Inverted T wave. Now T wave inversion is mainly in myocardial ischemia. So you see here there is no inversion of T wave. You can see the T waves are all upright. So it's again not a right statement. Third statement they said was shortened PR. There is no PR. Atrial ventricles are not having any relationship at all. So that's why rather than shorten, we'll have no PR. Normal QRS, yes, because the ventricles are having their own rate, so you will not have anything else. So that's why QRS would be normal. So the D is the right answer. QRS will show normal. Why? Because there's no problem. So QRS is normal. Why? Because there's no pathology in the ventricular system. That's a bundle of phase, bundle branches are all normal. So you can see QRS is very well. So it is height is also normal and the width is also normal. So what is normal? QRS will be normal. So answer is D for this particular question. Okay. Okay. Let's start the questions. Let's see other questions. So question number 2. So two students, Vineet and Kamlesh, we are asking them all the extra files. Okay. So two students, Vineet and Kamlesh, were asked to demonstrate in dogs the role of sinus nerve. Now sinus nerve come basically from baroreceptor. So baroreceptors give the sinus nerve. Sinus nerve. So baroreceptor give the sinus nerve. Okay. Now what do baroreceptor do? Basically baroreceptors will always try to decrease the BP. So they decrease BP by inhibiting VMC, which is the sympathetic center. So that's why sympathetic will fall and the BP will decrease. Okay. And their range of action is 60 to 180 mmHg. So if the BP is 60 to 180, baroreceptors are always decreasing the BP. Okay, fine. So if you destroy the baroreceptor, the BP will increase. So that is why on destroying baroreceptors, BP will increase. But problem is what? If the BP is already what very low, okay, then the increase is minimal. So if you cut at 100, it will increase. But at 60, the baroreceptors are minimally active. So at 60, minimum activity of baroreceptors. So that's why minimum increase in BP. And below 60, like 59, baroreceptor stop. Baro, and that's why no change in BP by baroreceptors. No change in BP. So now the BP won't be changing if the blood pressure is what value? It is 60 value. Are you clear? So the BP will be 60 value. Okay. Line. Okay. First degree, second degree. I'll explain. Don't worry. Okay. Clear. I just saw this. Okay. So I just saw the group now. Okay. Okay, so the baroreceptor will stop and no change in BP. So therefore, a person who is cutting baroreceptors at a BP of 100 will see a rise, 200 will see a rise, 150 will see a rise. But if someone is cutting at 85, the BP will increase. So BP will rise. 65 again BP. So both record a rise. So B both will increase or rise. Okay. So not the C. Okay. It's MBP range. Okay. So it is the MBP. Yes, it is the MBP which they are sensing. What I wrote now. So that's why baroreceptors will always try to decrease the BP, especially the MBP. So therefore, if you cut the baroreceptor, the BP will increase. The BP will increase. I hope it's clear. So that causes a increase in the blood pressure. Okay, fine. Okay, regarding first degree, second degree, just remember in first degree block, first degree AB block, the only thing to remember is there is just increase PR interval, just increase PRI more than 0.2 second, but no dropping of beat, no dropping of beat. That means P and QRS ratio remain 1:1. So that means every P wave is followed by a QRS wave. Okay, fine. In second degree, there's a beat drop. There are missing beats. Remember, easy mnemonic, missing beat, missed beats, also called as mo bits. So remember, mo bits, missing beat, mo bits is missing beats. So here some beats are missing. That's it. Mo bits is beats are missing. So mo bits phenomenon. Okay, done. So these are the concepts we are seeing or we are having. Okay, MBP. What you are asking MBP again? Suchi Charit, I told na baroreceptors are sensing MBP. They regulate the MBP. So if you cut the baroreceptor nerve, the MBP will increase. So obviously, if the Vineet who's cutting now at 85 and this 65, they both will observe a rise in the BP. No. Who said 70 to 150? Okay, the range is 60 to 180. Okay, clear, Charit? It's 60 to 180. Okay, some books have given the values differently, 70, 120, like but in India, most of the books we use the range as 70 to 180. Okay, clear? So don't go by that. Okay, otherwise you will not be able to get questions right, because there is always a controversy, like pacemaker respiration. Some books say DRG, dorsal respiratory group. Some say pre-Botzinger. Pre-Botzinger is the most accurate one. Okay. Okay, ECG of first, second degree. Let me show you. So I'm showing you the ECG of first and second degree. Okay. So this is the first degree block. Can you see? So in the first degree block, you see that the PR interval is much increased. Can you see? So it is 6 to 7 boxes. Can you see? So there are 6 to 7 boxes. If you take 6 boxes, 1, 2, 3, 4, 5, 6. So each box is 0.04. 0.04. So into 6 will give you 0.24, which is more than 2. But after every P, there's a QRS. Then P, then QRS, then P, then. So that means there is what? Normal interval which is present. So the interval is normal. Interval present here is almost normal. There is no problem in the interval whatsoever. So what is the only problem here? The only problem is there is a increase in the PR. Can you see? This is first degree. This is second degree. Mobitz 1 or Vanky-Bach. What happens here is there is a increase in the PR. First there is 5 boxes, 7 boxes, 10 boxes. Then there is no QRS. Then there is no QRS. So P wave, no QRS, P. This is the Vanky-Bach phenomenon. There's a drop in the beat. There's a drop in the beat. Again, it is Mobitz 1. And if there are always, you see, multiple P wave, like there is, okay? Okay. So I hope it's clear. So these are, so it causes multiple. So it causes P is to QRS ratio 2:1 or 3:1. That's Mobitz 2. So there's a frequent drop. So there is a frequent drop. I hope it's clear. So frequent drop is called as the Mobitz 2. Okay. So let's go back to our topic because this is not needed now. So let's come to the next topic, next question. So the next question is carotid arteries clamp above the level of carotid sinus. What is the possible outcome? Now understand, baroreceptor try to decrease the BP and the heart rate. Okay, clear? So there is something called as the Mary's law. So I know Mary's law. Mary's law. Okay. Now what is Mary's law and how does the Mary's law work? Okay. So we are seeing what law? The Mary's law. Okay. It say BP is inverse to heart rate. BP is inverse. Why? BP is changed by any pathological condition and heart rate is changed by baroreceptors. This is called as a Mary's law. Okay, Mary's law. Okay, so it's applicable whenever there's a massive change in the baroreceptors are causing this massive change. Okay, fine. So what do we see or what do we have? Okay, so first is in this case, let's say there's a shock. First is shock. So in shock, there's a fall in the BP. So Barrow will try to correct the BP by causing an increase in the heart rate. Are you clear? That's when shock, the heart rate is increasing. The heart rate is increasing. And then whenever there is a CNS ischemia, that is CNS ischemia, that is increase ICT. Increase ICT. What cause increase ICT? Answer is Cushing reflex. So BP will increase. BP will, but that cause our heart rate to decrease. So this causes a reflex bradycardia. So remember, whenever there is a CNS ischemia, the BP will increase and the heart rate will decrease. Okay. So now what happens? Let's see this in this concept. Carotid baroreceptors are present at bifurcation of. So let's say the carotid baroreceptor at bifurcation of common carotid artery. So the location bifurcation. So let's make this. So this is, let's say, the bifurcation and this is the heart. So this is aorta and bifurcation of common. Okay, so just make this diagram. So now what happens? Let's say these are the baroreceptors. These are the baro. This is the common carotid artery, ICA, and baroreceptors. So now what happens is if you clamp the carotid artery, the brain will not get the blood. So first question, clamping will cause CNS ischemia. And BP will always increase. That's something very, very important to know. So that's when stroke also, TIA or anything, okay, the BP will always increase because that is a physiological mechanism for BP correction. For correcting the brain blood flow. So now let's clamp above. So first scenario, if I clamp above, okay, what happens? And below. So I'll discuss both above and below. So this is below clamp. This is above bifurcation. So if you clamp below, what happens? First thing is baroreceptors are not getting the blood. So they can't sense the BP which is coming to them. So that's why the blood pressure coming from aorta carotid will not be reaching. So what happens? Baroreceptors get no blood and hence they have no activity. So baroreceptors are getting no blood and hence they are having no activity whatsoever. Okay, so they are having almost no activity in this case. Okay, so therefore what happens? They are unable to act, whereas above the clamp the barrow will be stimulated by the increased BP. So baroreceptors stimulated by increased BP. So now the barrow are getting stimulated by the increase in the BP. So what happens in this case? They will be able to decrease the heart rate. So Mary's law become operational. So Mary's law occur. So there's the reflex bradycardia. So there is a reflex bradycardia. So BP will increase, but heart rate will decrease. Okay, clear? So BP will increase by ischemia and heart rate will decrease by baroreceptor. But if we clamp below, what happens? The barrow will, okay, the barrow will not get the blood. So that's why the heart rate will also increase by ischemia. So now what happens? So heart rate won't decrease, rather increase due to high sympathetic from VMC. So that's why both increase. So BP increases, heart rate also increase. So now there is a increase in both BP and heart rate both. So are you clear? So BP, heart rate both will increase in this case. So what is the right answer we will see in this case? So let me just say. So what happens here? The answer is both are going to increase, BP also and the heart. So let me just see. So the best answer is there's an increased BP with bradycardia. Why? Because in above will get blood from the below, so they will act. So that's our answer is increased BP with, yes, bradycardia. I hope it's clear. So all of you understood. So both these questions are about the barrow. Okay, just 1 second. I'll get my water. 1 second. So let's continue. Okay. So next question is question number 3. Stimulation of parasympathetic nerves to the heart will cause what? They will cause what is? They will cause a inhibition. Yes, via what receptor? Via the M, via the what receptor? M2 receptor. So via M2 ACH, M2 inhibit the AC node. So that cause a yes, vasovagal shock and stop the heart, and the ventricles etc all shut down. So this is called as vasovagal attack, or it causes a vasovagal syndrome. And this is a vagal attack. Okay, so just vagal attack, and this vagal attack causes everything to shut down. Okay, now what happens? Ventricles are not supplied by the vagus. That's why they're first to come out of inhibition. So ventricles are not supplied by vagus. So first to come out. So first to come out of inhibition. So what comes out the first? The answer is the vagus nerve come out of inhibition the first. And once the vagus nerve comes out of inhibition, what will the vagus nerve do? The answer is the vagus nerve is not able to inhibit. So that's why it is called as vagal escape. And start beating at their own rhythm. Called as idioventricular rhythm. So what is it called as? It is called as the idioventricular rhythm. So what is the own rhythm called as? It is given the name of idioventricular. So the name given idioventricular rhythm is the case. Okay, so idioventricular rhythm. Okay, at own rhythm. Okay, what is the rate? All around 40 to 60 per minute. So what is it called as? Idioventricular rhythm. Ventricular. Okay. Now question is, so it is not working, the atria etc all. So therefore what happens? You will get QRS equal to T wave. Why? Because ventricles are depolarizing. Who's making the currents? Again the bundle of His. Okay, so this is because of ventricular depolarization and repolarization. So ventricles will depolarize, repolarize. Okay, and atria will remain shut. So that's why P waves will be few or maybe absent. So P waves are few or may remain absent as atria are under inhibition, as atria are inhibited. So that is why what you see is QRS complexes and T waves. Okay, and what is missing is the P waves are missing. Okay, so P waves are almost missing, or if they occur also they'll be very few, they'll be very few. So that is why what happens in this case is you will see the following. First, P wave become larger. Why will they become? Is there any hypertrophy? Is there any atrial enlargement? No. Fewer T wave than wrong. Why? Because they are always equal. They are equal, not more. There would be fewer P wave than T wave. No, no, no. Yeah, true. Why? Because the atria is not working. So it's true. It's true. It's true. There will be fewer QR than P wave. No, they rather QRS more than P waves because the atria is not. So it's also wrong. So the right statement is C, 4C. Okay, so answer is C. So I hope you all getting the answers. So 4C. Okay, see, Charit, you are right. Okay, when you clamp above the baroreceptors, understand, blood, it will cause ischemia. So BP will increase, and as BP increase because of what? CNS ischemia, it will cause too much pressure and high blood reaching the baroreceptors. Are you clear? And baro will be able to decrease the heart rate because they are working. If you clamp below, the baro will get no blood. So now the baro are not working down. So that's why they cannot decrease the heart rate. So very simple. If baro working, they will cause the Mary's law, that will they will decrease the heart rate. But if baro themselves are not working, the heart rate cannot now decrease, it rather increase. So now the Mary's law is not applicable. That's why clamp above the high pressure of the heart, BP is increased now. So this increased BP stimulate the baro and cause the BP to heart rate to decrease. Okay, so I hope you all understood. If we cut it by, it depends how much is cut. Okay, clear. Second, if you cut, then you will die. So yes, if you clamp at the bifurcation, then we were suspecting that it depends what activity will be gone. Okay, so if you clamp here, maybe some baroreceptors are gone, some are working. So that's why depend on now the severity of clamping. Okay, if it's clamped very well and no blood reach the barrow, then obviously the heart rate will not. So simple question, if barrow are working, they will do bradycardia. If they are not working, they will fail to cause bradycardia. So most of these conditions, there will be no bradycardia if barrow are damaged. Okay, fine. So bradycardia done. So all of you understood? Chalo. So let's see question number 5. Okay, first, let me just see the questions they're asking. So I'm reading the chat also. Yes, it is similar, but see, it is what we have discussed already. The first ECG I showed you was actually that idioventricular rhythm, where the ventricles are beating at their own, but there the P waves were there, but here the P waves are absent. Are you clear? In stroke atom also P waves are present, so that's why the P waves. See, baroreceptors are having no effect. They have an effect on BP, but understand, in case of pathological changes, the BP cannot be corrected back to normal. The baro are trying their level best. In shock, baro are trying to increase BP, but they fail to increase BP. Are you clear? So that is why BP is not corrected. Heart rate is showing a compensatory rise. Are you clear? So what baro are trying to do? They are trying to increase both BP, heart rate. What they can increase heart rate, because that is normal, but what they fail to increase, BP they fail to increase. So BP they fail to increase. I hope is clear. So what is not increase? The BP is not increase. Are you clear? So BP will remain low. Okay, fine. So I hope is clear. Maybe fewer QR than P wave? No, they rather. Okay, so I hope everything is fine. So got the answers, Rohan? You understood? So I think I've replied to all the queries. Zorami, Shah, Rohan. Chalo, okay. So let's move on, okay, and see the questions. See, they are all clinical questions, okay. Whatever question I'm giving you, they are the clinical, because nowadays the trend is what? Mostly clinical questions are asked. They are one-liners, I'm not denying, but mostly we are giving clinical questions for you people, okay. Chalo, let's move on. Now, stimulation of. So this is done fifth, okay. So there is a shock. The patient with shock. So you can see the BP is low. So shock is the condition, and most likely a hemorrhagic shock at that, because there's a loss of blood. Okay, so what physiological response would be seen at this? Okay, so first in shock, what happens? There is a decreased blood volume, so that causes a decreased venous return, that causes a decreased EDV, and that causes decreased stroke volume, cardiac output, BP, and heart rate will increase as a compensation. That is Mary's law. This is the Mary's law. So now the heart rate is increased. Okay, now also increase sympathetic cause what? Increase sympathetic via baroreceptor cause what? It causes heart rate to increase, also cause vasoconstriction. Vasoconstriction. How vasoconstriction? It causes via alpha 1 receptor, mainly in the GIT. That's why we use IV route to give the fluids. Also in the so GIT, also skin. That's why there's a cold, pale skin, okay, and also muscles. So that's why the person cannot move. So muscles are also in a paralyzed state, okay. So muscles are in a paralyzed state. Also what yes, the liver, etc. Also very important, kidney. So that's why all is there. So all these, and the result is what? There's a increased peripheral resistance. So increase PR. So these are the changes we will see in the shock. Plus RAS become activated, also stimulate the RAS, which cause increased thirst, etc. Also stimulate RAS, reticular activating system. Okay. So all these are parts of what system? They are the parts of your shock compensatory mechanism. So let's see. First, venous rhythm will increase. No, it will decrease. So it is wrong. It will decrease. GFR, no, it will decrease because there's a renal vasoconstriction. Peripheral vascular, yes, it increased because of yes, vasoconstriction. So it's increased. So this is right option. So answer B is right. So B is the right answer in this case. I hope it's clear. Yes. Okay. So let's continue the questions. Chalo. So all going good. Chalo. See, strokes, Adam, is what I discussed. It is a third degree heart block. Okay, Kirthana. So what I discuss here that at independent, this is called Stokes-Adams syndrome. So first I discuss Stokes-Adams syndrome. The ventricle and atria. So third degree block. We will use the alpha 1 for vasoconstriction, not beta. If you clamp above, the baroreceptor will get the blood and they will cause bradycardia. Okay, Arzu? So bradycardia if there is clamping above. Okay. So third degree we have what? Stokes-Adams syndrome. Stokes-Adams syndrome. Okay. And that what happens, the ventricle start their own rhythm. Okay, so ventricles start their own rhythm, and that's why. Okay, let me just check the audio. Okay, first give me a time. Okay. Okay, now is the sound okay? Is the sound okay now? So am I audible perfectly now? Okay. So just change the sound settings from my system itself. So I'm using a makeshift system. So don't worry. Okay. Ciao. So if BP increase, yes, if BP increase, baro will decrease. Like in shock, if BP decrease, baro increase the heart rate. So in case of clamping, CNS ischemia, baro will sense the high BP and decrease the heart rate. So just remember this thing, that in shock, there is decreased BP and baroreceptors will decrease the heart rate. Are you clear? And in clamping, okay, or CNS ischemia, what happens? The BP will increase. So again, baro will cause decrease heart rate. Now, is it clear to all of you? So something I discussed, but remember for that baro should work. So if they stop, then heart rate will be high. Heart rate will be increase. Example, clamp below. If you clamp below, obviously they will not get the blood. So baro will not work. So they will fail. Okay, clear? Himanshu, you are right. In shock, the Kappan's vessels will try to increase. But you are asking first, he's already in shock. That means they have failed to give correct correction. So again, you are getting confusion. So if they are, see, like baroreceptors are trying to increase the BP. If they correct the BP should become normal. If BP is low, that means they have failed to correct the problem. Okay, Himanshu? So what is the answer? So they will. So like I give my blood. So I give 1 unit blood. So what happens is my volume is decreased. So I should go in shock now. But my veins constrict plus the RAS system plus baro. So my BP remain normal. That is compensated shock. Are you clear now? So BP will be normal. In decompensated, the return is increased but still below the normal level, hence BP fall. So that's why you're misunderstanding the two. Okay, so therefore the compensation is not correct. So compensation is not correct. Okay, fine. So it is falling. Okay, so not corrected properly, not corrected completely by kappa signals, by veins. Are you now clear? So got the answers, Himanshu? Should I move forward? Okay, okay. Location of alpha? What location of alpha? Robin, what alpha? Alpha receptor. See, alpha receptors are present in the organs, okay? It is in GIT, skin, muscle, kidney. Okay, these organs contain alpha 1 and also they are on the veins. causing vasoconstriction. So these are the location of alpha 1 receptor. Beta 1 is the heart, na? So beta 1 is in the heart. So the heart rate is increased via beta 1 heart. Beta 2 cause vasodilation, which is not here out. Okay. So I hope everything is clear. Sure. So let's continue. So I think I should I move? Sure. So I'll reply to queries after I finish 3-4 questions, because then the flow will break, because I have to go back to the again the phone, check the this, then again. So let me just go on. Whatever doubts you have, you post. Okay, you post the doubts. Okay, and I'll keep taking them after the questions are over. Okay, clear? Like 3-4 question over. Like abhi cardio hour, I'll take the query. Otherwise, it'll break the flow. Okay, let me just go for the questions. Okay, yeah. Chalo. So in this PV loop, what is C? Okay, so let's start the question of PV loop. So let me just discuss the PV loop for you people. First is the cardiac has the following phases. Okay, so what are the phases? It is S1, S1, S2, S1. Okay, yes. Because I think now the audio video quality is also good. Initially, I agree. The audio was lacking from my end, so I increased the bitrate. So everything is perfect. So now let's do the questions and we'll go for this correction. Okay, and we'll take a break around 5:30. Okay, and then do the remaining questions. Okay, so let's for 1.5 hours do all the questions and take the doubts in between. Like I'll finish these questions at the end of CVS. I'll take the doubts. Okay, chalo. Thank you very much. So because I have to keep shifting in between. Okay, chalo. So that's what I keep doing. Okay, so I'll shuffle from here, then I'll shuffle and I'll go to chat. Okay, so I'm shuffling between the two. So again, not all vessels have same alpha beta. Okay, some have more alpha, like skin will have very less beta 2 but more of alpha 1. Okay, that's why they are. Plus also prostaglandins play a key role in kidney blood flow. Okay, and type. Clear? Like sweat glands, they have mainly vasodilation types. Okay, beta 2. Okay, so let me just move on to the class. Okay, now what is S1, S2? It is systole, and this is diastole. Now what happens at S1? What happens at S1? So at S1 there is a closure of the AV valve close. AV close. AV valve close. Since we are discussing the left ventricle, I can just say there's a mitral valve close. So MV close, mitral valve close. And now the ventricles are in a isovolumetric contraction till the aortic open. So now aortic open. So this is called as isovolumetric contraction. Here there's an increase in ventricular pressure, but volume is same. Now there is ejection period. There's a decrease in the volume. Why? Because the stroke volume is going out. Okay. Now at S2 the aortic closes. Aortic close. That causes S2. And now what happens? Ventricles are relaxing. So there's a isovolumetric relaxation. Isovolumetric relaxation. Okay. And this relaxation occurred till the mitral valve open. And once mitral open, you do filling. You do filling. Okay, so now here the pressure decrease Vp. So here and now the increased volume is there, and it fill up to EdV, that's N dash to the volume 120 to 130 ml. So this is the summary of cardiac cycle. So let's apply this to get all the periods perfectly fine. Okay, so let's use it to fill it up. So I'll make this graph. So first is we'll start where the AV valves, that's the mitral valve open. Okay, so let's say volume right now is very low. It is just 50 ml. It is just 50 ml. Okay, this is 130 ml. So obviously 130 is the filling phase. So you will have to fill. So what happens at this? And the pressure 80 is the pressure. This is pressure 0. This is volume. So first is what happens at point number this. The pressure is almost 0. So this is pressure is 0. This is point, let's say which one? A. Okay, so we're using this as A. Yes. So at A, open. So at point A, the AV opens. So this is the A point. AV opens. The mitral valve open. The moment mitral open, the filling starts. So the volume will increase and slightly pressure also increase. This is filling phase. And this is EDV. And diastolic volume. Now at B, the AV valves should close. That is the mitral close. So at B, mitral close, mitral valve close. So it goes with sound S1. And now the pressure will increase. So now the pressure will increase. So this is which one? This is B. And now B is here. So what start after B? So filling is over. Now what start after the filling? The isovolumetric contraction. The pressure will increase. So pressure will increase. And at C, the aortic open. Aortic open. I will write here. So at C, this is C. Aortic opens. Aortic. So this is isovolumetric contraction. Isovolumetric. So just labeled everything now. So this yellow part is the filling part, which is from A to B. So filling is A to B. So A to B. Then this blue part, from B to C is the isovolumetric contraction. This is B to C. B to C is isovolumetric contraction. Now once the valves open, because the ventricles are now in the ejection period, so the pressure will rise very high and then falls. This is SVP, systolic pressure, and this is the rise in the pressure. So this is now the D. At D, aortic valve close. So at D, the aortic valve close. So that is D point. Okay, so this is the D point. Okay, so now the aortic valve close. So what is C to D? This is the ejection period. So C to D is the ejection period. Ejection. Okay, and in ejection you eject how much blood? Almost 70 ml blood, which you can get from minus. This is stroke volume. Stroke volume SV around 80-70 ml. So 130 minus 50, and at this point now the ventricles are in relaxation mode, so they are in isovolumetric period. This is DA is isovolumetric relaxation. So now the pressure will fall, the pressure will decline, the pressure will fall. Okay, so this is the case. So this is the pressure volume curve. So at the this is ejection, just labeled. This is ejection. This is isovolumetric relaxation. Okay, sure. So let's solve the question. So saying EDB as what point? So obviously, and what is this point called? This called as ESV, and systolic volume. So it's the and systolic volume. Okay, so let's see question number one. Okay, so what is AB filling? So AB is filling. This is iso contraction. This is ejection, and this DA is iso relaxation. So obviously, the EDB is point B, and ESV is point A. Okay, CD is ejection point. Okay, CD is ejection. Okay, so I hope it's clear. Answer is B. Next question. A 6-month-old infant is brought. Main thing is a wide fixed heart rate is normal 100. Okay, temperature is also normal 37. Respiratory is also normal. So they're all and ASD. That's first is asymptomatic. First thing is asymptomatic. As per the NADA's criteria, there is no sign symptom, no cyanosis. There is no cyanosis. There is no murmur. Okay, so that's why first thing there is asymptomatic. Okay, and most ASDs are asymptomatic. Okay, clear? So most ASDs are asymptomatic. Okay, now what happens in ASD? First is there is a opening between the two. So the most common, I ask a question, what the most common type here? What the most common type of ASD? Question for you people. What is the most common type of ASD? TND batch? Give the answer. Shantana, Navya, Shashidhar, Suchi, Swati, Janu, all. What is the answer? Which one? Yes, secondum is most common. Very good. Okay, so ostium secondum. Ostium secondum. Very good. Okay, and where do you see ostium primum? Primum is in which condition? So ostium primum is seen in which condition? Yes, second. Very good. Okay, you are all right. Himanshu, Prashant, Elias, Arzu, Nikhil. Yes, downs. Very good. In downs, it is ostium. But down is primum. Okay, so down is primum. Okay, prime. Okay. Now let's start. So what happens in the case of ASD? The shunt is there. So what the shunt? It's a yes, left to right shunt. Left to right shunt. So what happens is the blood go from left ventricle to the right and right goes. So that's why the blood keep going to lungs. So what happens? Increase blood flow to lung. Increase blood flow to the lungs. And if there's an increased blood flow to lungs, what happens? So first, this is asymptotic. In synoptic, like TOF, this is the pulmonary stenosis, the blood will not be going to the yes lungs much. So that's why cyanosis there. So that's why the baby is asymptotic. Second, since there is more filling of the right side, it will take a longer time for blood to go. So that's why second, increase venous return to right atria from left atria and RV. So that is why there is what? Increase pulmonary blood flow. So take more time. So that is why it take more time. Okay. Okay. See, right to left shunt. Remember, right to left shunt are seen in synoptic condition. Okay. Clear? So understand. Okay. So there are 5 T's and 2 E's, which are synoptic. Okay. And 3 D's are asynoptic. Or the 3 D's, they are ASD, VSD, and PD. So all have D's. So all D's are acyanotic. All D's are acyanotic. And the T's and E's are cyanotic. Which T's? Tetralogy of Fallot, TGA, this transfusion grade vessels. Then TAPVC and tuatata, ta and ta, tata. Truncus arteriosus, tricuspid atresia. And E's are absinomaly and Eisenmenger. They all are examples of what? Cyanotic heart disease. Okay. So these one, Robin, are the ones. Okay. See, saturation of all chambers equalize. Okay. So it will be seen in a massive, you can say ASD. Okay. Where there's such a mixing that almost all will get the same value. Are you clear? So that will be a massive amount of ASD, because VSD will not be affecting the atria much. So it will be a massive ASD which cause. So now what happens is, understand, the blood will keep going to the lungs. The blood will keep going to lungs. So what happened? So first question is more time. So take more time to, yes, pump. That is why the pulmonary valve close later. So pulmonary valve close later. So that is why P2 is delayed. So causing A2 gap. This is called as wide fixed split. Wide fixed split. Second thing, since more blood is going to the lung, since more blood is going to the lung, it is acyanotic, and therefore the oxygen level in the blood are very, very high. So there is a increased oxygen level in the blood. The cyanosis is not there. So let's see the question. O2 saturation decrease. No, it is increased. Why? Because of blood going again to lung. So left ventricle give to right, right give to lung give the oxygen. Again, so that's why the blood is getting more and more oxygen. That is why the lungs are filled with oxygenated blood. Only problem, this blood is going less to the body, but because of high oxygen content, it compensates. So body is getting less blood because the left ventricle is giving to the right. But what is happening is there is still lots of blood coming. Okay, so that's why the blood is there. Okay, then increase in right ventricle. Yes, it is true. Decrease? No, it is increase. Why? Because more blood is coming from lungs back and back to lungs. What is happening? The understand, right ventricle give to the lungs give to the left ventricle, and left ventricle and left atria. Okay, so just write it like this: left ventricle, and this is the case. Okay, this is right atria. Okay, and it goes to what? It goes to the left atria, and then it goes to the left ventricle. So left atria is giving again. So that's why more and more blood from the lung is going to the this. That's why it is getting less blood. So less blood is going from left atria to left ventricle. More is going back and back to lung. So that is why there is a oxygen rich blood flowing in the heart. Oxygen rich blood is flowing in the heart. Okay. So it is the right answer. The following is not a measure of stroke volume. So you've done this question already. Let me just re-emphasize. Okay. So understand, first question is, okay, so what is stroke volume? It is EDV minus ESV, which I discussed already in the pressure volume curve is stroke volume. Second, we can also write it as what? Stroke volume as cardiac output is stroke volume into heart rate. So vice versa, cardiac output by heart rate is stroke volume. So cardiac output, and what is ejection fraction? Ejection fraction is stroke volume by EDV. So what is stroke volume? It is ejection fraction times EDV. So these are three main formulas we are having. So let's solve. First, EDV minus ESV. Is it right? Yes, true. Ejection fraction times left ventricular EDV. Yes, it is also true. That is ejection fraction times EDV is also true. Ejection fraction times cardiac output. Okay, let me see this later. And cardiac output by heart rate, true. It is also true. Let's see this option. It's a EF into cardiac output. That will give me SDV to EDV into stroke volume. Are you seeing something? So this is the case. Okay. Pink, I told you, na, in case of a massive ASD, the oxygen level will increase in all the chamber. Why? Because the oxygen coming from the lungs will go to left atria and left will give to right. So right will start getting more and more oxygenated blood, okay? And then this right will give to right ventricle. The right ventricle also get lots of blood, and this will then go to lung and become more oxy-rich, and ultimately left atria will give the same oxy blood. So after some time you'll get a very high oxygen in all the chambers, okay? Massive ASD, not small one, massive ASD, okay? Fine. Okay, so is it clear? So the right answer, it is C. C is not correct. So just give me what? Stroke volume square into heart rate. What is this? I don't even know what this is. So this is a very tricky thing. Clear? So very tricky thing. So is the following cause a decrease in stroke volume compared with the normal resting? So let's start this question. So first is what after is resistance, is peripheral resistance. So obviously if there is a decrease in the resistance, heart will be able to pump more blood, okay? Again, in tricuspid regurgitation, the problem will be what? The blood will go more and more back to the which one? The right atria, but the amount of blood going to the lungs will not be much. So yes, it can also cause, true, okay, Robin? TR can also, but she's asking congenital heart disease, okay? Clear? So they were asking congenital heart, okay? Answer C, na? C, answer is C. Answer is C, okay? So congenital will be ASD, better answer, okay? Not VSD, because in VSD the atrias are still having different oxygen level, okay? It is the ventricles which will be having mixing, okay? So it is PR, it is the PR, okay? So that's why the heart will find it easier to pump, okay? So that's why the answer would be PR, okay? So in this case, now increase in end diastolic pressure, okay? Now if EDP, that means there's an increase EDV, and increase EDV cause what? Increase stroke volume by Frank Starling law. Which law? Frank Starling law. Okay, clear? So if there is a reduction of resistance, obviously the heart can pump more blood, okay? Because the cardiac output depends on what? It depends on the filling, that is EDV, but also depends on the resistance. So if resistance fall, the flow, because the formula of flow is what? Flow is pressure by resistance. So flow, that is the cardiac output stroke volume. So if resistance decrease, the flow will increase. Flow is amount of blood pump. So that is the case, okay? And what is flow? That is, let's say, cardiac output. So cardiac output will increase, and we know cardiac output is what? Stroke volume into heart rate. So that's why when you decrease the resistance, the heart can pump much better, okay? So heart can pump much better, okay? So one is right, it's true. B is also true. Vagus nerve. If you stimulate the vagus nerve, there's a decrease in heart rate. If there's a decreased heart rate, it cause what? It cause a longer diastole. Longer, and that cause increased filling. So longer diastole will cause a increased filling of the blood, and an increased filling of blood will obviously cause what? It will cause what? Yes, a increased filling will cause a increased EDV, and that cause increase stroke volume. So they all increase the stroke volume. Till now, we have got all increasing stroke volume. But when you increase the heart rate, reverse occur. So increase heart rate, less diastole, less filling, less filling. So at very high heart rate, the filling is so less that it causes decreased stroke volume. Now there is a decreased EDV and decreased stroke volume. That's why D is the best answer in this case. Are you clear now? So D is the best answer. Okay. Question 9. So which of the following is not true for cardiac and skeletal muscle fiber? So first question, let's go. Okay. Graded contraction. Graded means that you can decide how much is contraction. So remember, first thing, smooth muscle, that is a visceral smooth muscle. Example, bladder. Example, bladder, uterus, GIT, etc. And heart, cardiac muscle. See, the flow, that is the amount given by any organ to the by heart, depends on pressure and resistance. Okay, I'm explaining Bharat. Okay, and resistance is also called as peripheral PR or afterload. So afterload is a type of resistance. We know this. So if you dilate a vessel, the resistance will decrease. And if you dilate, obviously flow will increase. And the flow of blood to the organ is called as cardiac output. So cardiac output increases when you decrease the afterload. So organ get more blood. Are you now convinced? Okay, Bharat Kumar, NS. So now you're getting more blood. And that is because of a normal increased cardiac output. There is a increase in the cardiac output. So what's happening here? The cardiac output is increased. The cardiac output is increased. So obviously now the stroke volume into heart rate equation will show a increment in this case. Are you clear now? So you will get a increase in this particular situation now. Okay. So stroke volume into heart rate will increase. So stroke volume will increase. Now you understood, Bharat? So if you dilate a vessel, resistance afterload will fall and that causes increased flow. So that is why decreased resistance increase flow, and flow is nothing but stroke volume, cardiac output. Okay, so again increases stroke volume. Done. Okay. Now let's come back. See. So that's what break the flow. Okay, so let me first explain the points. Okay, and then I will explain all the doubt later. Okay, so they are basically, and heart, cardiac muscle, they basically have gap junctions. So they have the gap junctions. They have gap junctions. Okay, now because of the gap junctions, what happened? Okay, all fibers are connected to each other. Okay, so gap junctions connect fibers. So gap junctions will connect the fibers. So that is why what happens, all fibers get excited and contract at same time, and contract at same time. That's why they act as single unit and able to pump the blood or pump the bile out or the baby out, because they are acting as not multiple fiber but single, also called as syncytium. So that's why they follow all or none law. Follow all or none law. Clear? So follow which law? All or none law. So follow the all or none law. So I hope it's clear. So all or none law is the concept. Whereas skeletal muscle, they have motor units. So each unit contract at different time and different number. So that's why you can grade the contraction. That is why skeletal muscles, they have very few gap junctions and the fibers are split into units. So fibers divided into motor units, so that you are able to recruit or excite any number. So that is why we can do graded contraction, where we can contract 10 units, 20, 50, 30. So we can decide the amount. Let's say I want to lift this pen, so I need small force. But if I want to lift this glass, I need a heavier force. So that is why the force value will change. So that's why we can decide to change the force. So we can decide to change the force in this particular case. Are you clear? So force can be changed. Okay. So that is the first statement is wrong. So it is false. It is false. Second, excitation both. Yes, yes, yes. It is true because they both use calcium from sarcoplasm. Remember, skeletal. So first question, skeletal and the cardiac muscle. Calcium from sarcoplasmic reticulum, that is ICF. So they have their own source, whereas smooth muscle don't have a well developed SR. So smooth get calcium mainly from ECF outside. That's why they are very much dependent on the extracellular calcium level. So that's why smooth depend on extracellular calcium. Okay. Next question. Excitation contraction coupling is not dependent on extra. True. Again true. Okay. So the coupling depend only on SR calcium. So that is only SR, which is intra SR calcium, not the extracellular. Okay. Excitability, etc., RMP, etc., are affected by extracellular, but not the contraction. Contraction depends on intracellular calcium. Okay. Cardiac has long plateau and refractory. Yes. Why? To protect from abnormal excitation. So it has the following periods. So this is the phase 0 depolarization. This is phase 1 early repolarization. This is phase 2 plateau. This is phase 3 late repolarization. And phase 4 is RMP. Okay. Phase 4 is RMP. Okay. So clear? Okay. So answer is A. 10 is A. So that is false. I hope it's clear. So 10 is A. Shreya, these kind of doubts I'll explain later on. Okay, clear? Let me first finish the questions. Okay. So just remember this sign I'll explain. Okay. Yes, it depends on extracellular calcium. Okay. I'm telling you, okay, doubts I'll take later, okay, clear? Else I'll be not able to finish, okay? Because these are topics which are extra, okay? Like the plus and minus sign, what they are decided by is first, if cation is coming inside, use a plus sign. Example, sodium, calcium, okay? Sodium, calcium. If cation is going out, you're losing plus, okay, and I'll tell you, okay? It will cause a minus sign. Example is potassium. So potassium has a negative value. It has a minus 90 value. Okay. If anion coming inside, if anion is a sign for Nernst equation. Okay. So if anion coming in, okay, it will create a negative sign. Example chloride. Okay. And vice versa, if anion going outside, that will give a positive sign. Example, and please don't ask me how to apply this because it need again full discussion of the Nernst equation, how the concentration achieve the role of protein. Okay, so that will be becoming very difficult. We just have 6 hours. Let's discuss the concept which are already marked in the questions. Okay, so is it clear, Robin? Robin kya Shri Haita. Okay, so that is how you put the signs. Okay, Robin, yes, the visceral smooth muscle require mainly extracellular calcium for the contraction. Okay. Okay, I told you hyper and D. If sodium and calcium influx, it create depolarization. Okay, D. Okay, clear? But if you block or stop, if you block the sodium channel, it cause a hyper. Okay, if block sodium calcium channel, the influx is blocked, it cause a hyperpolarization. Okay, so it cause a hyperpolarization. Okay, vice versa, if there is a potassium efflux, or yeah, please give me time to at least post and explain the concept. Okay, or chloride influx, it'll create negativity that cause a hyper. And if we block this channel, if we block potassium chloride channels, then depolarization will occur. Depolarization will occur. Okay, clear? So I'm explaining the queries one by one. Okay, and I'm requesting you, okay, please ask the queries after I have finished this system. Okay, otherwise it'll be problem for me to again go back, explain the question, come back. Okay, clear? So let me explain this. Okay, now this is done. Okay, Robin. NS, what is longer refractory period in question number 10? See, refractory period is a period in which you cannot stimulate the tissue. So it's a period in which we can't stimulate the tissue again. Can't stimulate tissue again. Okay. Now two types are there. If it is absolute and relative. In absolute, we need to give a stronger stimulus than also. So no response. And relative, we need a stronger stimulus. Stronger stimulus. Are you clear? So that is why what happens, absolute refractory period will prevent arrhythmia. So it is, so therefore it prevent excessive stimulation. So prevent abnormal stimulation like arrhythmias. So it is a safe period. So that is why it is a safe period. So which is a safe period? Absolute refractory period, ARP, and this is R. So ARP is a period which prevent arrhythmia genesis. Okay, fine. And what is ARP? Is basically early repolarization. It's the early repolarization. Okay, so that's why when you increase plateau, it become a part of early, and it is mainly late repolarization. Late repolarization. Okay, because the sodium channels are not responsive here. Okay, so late repolarization, and this is early repolarization. So early repolarization. Okay, and it is basically, that is why plateau period will add or increase. So that is why a plateau phase increase it. Okay, so it will increase. Okay, fine. And late repolarization is the part which is near the RMP, so that's why you're not affecting it much. We are mainly affecting the early phase. Okay. Okay, Suchi, longer refractive, yeah, okay. So longer means, yes, longer means they are safe from arrhythmiogenic stimulus, okay. So ARP should be long. So that's why plateau phase, okay. Smooth muscle depends. See, it depend on the extracellular calcium for the contraction. Intra is very less because SR is not well developed. So yes, it can use intra also and extra, but intra is very less. So that's why primarily it is a extracellular. Okay, Monica. So I hope I've replied to all the queries. Okay. NS, Robin, Shri Haita, Suchi, Medico. So I think I've replied to all the queries. Should I move on? Okay. Chalo, okay. So let's see. Okay. Clear? So now question is what happens in a athletic person. So first is what the formula for O2 consumption. Okay. So remember oxygen consumption per minute is given by cardiac output times arteriovenous oxygen difference. Okay, so cardiac output times arteriovenous oxygen difference. Okay, okay. Now let's solve the question. So it say it is 4. I'll use the ml because that's easier for me. 4000 ml per minute. Cardiac output they have not given, so let's just say KO, and the difference is yes 19 and 3. So it is 19 and 3. So that gives 16. So just write 16 ml per 100 ml. So 16 ml per 100 ml. Okay, clear? 16 ml by 100. Okay, yes, it is fixed principle. Yes, it's called as fixed principle. So it's used for calculation of cardiac output also, blood flow also, O2. So let's solve this question. Okay, and now what happens is it will go to that side. Okay, so now cardiac output would be given as O2 consumption by AV difference. So that will be 4000, yeah, rather I'll just take 4000 into 100 ml by 60. So that give you, let's cut this out. So it give me 4, and again I cut it out, it'll give me 25. So 2500 ml per minute, and that is 25 liter. 25. So what is the cardiac output? 25 liter per minute is the cardiac output. So let's see this. So 25 is right answer. Okay, now this is not the right, it's not 12, it's 25. Stroke volume is 67 and 180. So let's calculate that also. So first is cardiac output is stroke volume into heart rate. So that will be giving this. Okay, so we can also say cardiac output by heart rate give you stroke volume. So let's solve this question. So what is the cardiac output? So I'll just show using calculator. I know the answer is 138, but still I'm doing it. Okay, so 2500 divide by how much was the heart rate? I think 180 or 140. Let me just check. It was 180 by 180. 180. So let's give 138 point something. Okay, so 138. So what will be the case? So it will be again 138.8 ml. So what's the value? 138.8. Okay, so is it true? No, not true, because they are saying 67 wrong. So the only answer is B. Answer is B. That is 25. Okay, fine. Next question is flow volume curve. So let's solve the question of flow volume curves and we will see. So let's see the flow volume curves. Okay, so first is we use mainly flow volume curves for obstructive lung disease. So now remember there are two kind of obstructions. One is fixed airway obstruction, other is variable. Now in variable the obstruction act in such a manner that both inspiration and expiration are very poor. So very poor inspiration and expiration. Array, let me explain, Swati. Okay, let's solve this question, then you give the reply. Okay, so inspiration, expiration, both are very, very poor. And in variable, it is one phase affected more. One phase affected more. So what is affected more here? One phase is affected much, much more. Okay, clear? Okay. So let's solve the question. So there are two types of variable. One is variable. I'll just write Y2 and V2. So what is Y2? It's variable intrathoracic obstruction. Variable intrathoracic obstruction. So variable intrathoracic obstruction and variable extrathoracic obstruction. Okay. So in this case, it's mainly expiration which is poor. Why? Because the intrathoracic airway get compressed when you expire. So its expiration is poor. Example, and that's why the sound is expiratory wheezing. Okay. Wheezing is the sound. And example is COPD, asthma, bronchiolitis. All are intrathoracic obstructions. So they are intrathoracic obstructions. Okay. Whereas in V2, that is variable extrathoracic, the inspiration is mainly affected. And stridor is the main sound. So main sound is stridor. And example is, let's say we'll say laryngomalacia, tracheomalacia, okay, or diphtheria, or any problem in the upper airway like this laryngotracheomalacia. Okay, so all this will cause problem in the upper airways. Okay, clear? So extrathoracic, where the mark, it is above sternal notch, above sternal notch, so called as this. Okay, yes, obstructive sleep apnea. So they are above, yes, OSA. So they are problem here, they are above the sternal notch, they are called as extra. Okay, so now what happens is, if there is any such problem which is above the sternal notch here, will cause this. Okay, now what is the reason is, when you people inspire, there's a negative pressure in upper airway which is pulling the air, so soft tissue are also pulled, and you know airway size decreases as you go down. So that's why this soft tissue, if it goes into the airway, it will cause, here it's not causing obstruction. So that's why in inspiration the airway get narrowed much more. Okay, but when you expire, they are blown out and the airway open. Whereas in this case, as there's a expiration, thoracic pressure increase, and now what happens, as there's the increased pressure, the airway which are inside the thorax, they get compressed by high pressure. So that's why here the problem is mainly in the expiration. So this is thorax. So the thorax will compress in expiration. So that's why problem is more in expiration. Here the problem is more in the inspiration. Okay. Let's see what the normal flow volume curve. So normal flow volume curve. Okay. So it has basically two parts. First is the volumes. Okay. It can give you vital capacity and others. So it can give you VC, etc. And these are the flow rates. These are the flow rates. Okay, so these are the flow rates. Okay, in liter per minute and liter per second, both we can use. So 0, 5, 10, 15, 5, 10. it is liter per second. Okay, now this is plus, this is plus, and this is plus and minus. Okay, now plus, the plus ones. Why plus? Because the person is expiring, the person is expiring, and if the person is expiring, obviously the flow rate is improving. What's happening? The flow rate is improving. When you expire, the flow rate will improve, so that's why it is plus. Okay, so that's why it is expiration. When you inspire, the machine lose the air to your lungs, so you are losing, so it causes a counterclockwise movement. So that's when you expire, the machine record plus, because you're giving air to the machine, and when you inspire, the machine lose the air, and the clock, that marker, moves anti-clockwise. So that is why inspiration. It's just a convention. You can create a machine which give opposite sign, but convention is what? Inspiration is below, expiration is above. Okay, so now what is the shape of the graph? This is inspiration, and this is called as PIFR. That is, yes, it is called as PIFR. What is PIFR? It is peak inspiratory flow rate. Peak inspiratory flow rate. It is around 5 to 15 liter per second. Called as what? Peak inspiratory flow rate. Okay. The person will expire. So initially the air climb up very fast, and it declines. So this is called as two values. This is PEFR, and this one is called as MEFR. So I'll write them there. So first what's PFR? It's peak expiratory flow rate and mid. Okay. So peak expiratory flow rate and MEFR. That is mid expiratory flow rate. So first is, it is mainly from larger airway, mainly large intrathoracic airways, and this one is coming mainly from smaller airways. Smaller airways. So it's mainly coming from smaller airways. Okay, clear? And that's why it is a lower value. So it's a lower value. Okay, so it is around yes, 3 to 5 liter per second, and this is 5 to 15 liter per second. So that's why it is more sensitive for small airway obstruction. So that is why for smaller airway, like a small bronchioles, or example, small bronchioles and alveolar ducts. Small bronchioles, alveolar ducts. Okay, so they are affected. Like example, COPD, emphysema better, right? So emphysema, we are affecting this. Okay, so that's why they are affected in this case. Okay. Okay, I'll try to send the notes. Okay, because my handwriting is so poor. I write something here, so I'll try to make a PDF and give you. Okay, but I don't think it'll be. If anyone making PDF, my request to all the students who are giving the watching this right now, if you are making a PDF, please do share, because my handwriting is very poor. I will make a PDF and upload, but it will be not a good one. I know that. Okay, so now what happens is, first remember the normal shape. First remember the normal shape. Okay, so anyone writing, they can send photos. I'll make a PDF myself. Okay, so anyone writing them down or using an iPad or some writing device with pencil, they can also do the same. Okay, okay, I will send. Okay, but point is, I know the quality will be very pathetic. Okay, so okay, I will send. I'm not saying I'll not send, but I'm telling you the quality will be pathetic. Why? Because when you make a PDF, the resolution depends on the page aspect. So if I write like this, the PDF will not be able to categorize when to finish the page. This is becoming almost like this. So you have to zoom in to see a word properly. Okay. So anyways, I'll give. First, let me finish. Okay. Now what happens is, remember the normal first. Remember it like a birthday boy. So which boy? Birthday boy. Now it can be girl also, so I'm not sexist. So boy or girl both. Nowadays people are very sensitive. I say only sir, why not girls, sir? Sir, are you discriminating, sir? No, no. It can be boy or girl. So he is very happy wearing a birthday cap. Okay, so birthday cap. Okay. Remember the boy has a very inspiring face. Inspiring face. Okay, so very inspiring face is there. So what is the face? It is very inspiring. Okay, okay, and he's having a mountain of expectations. So remember, face are semicircular here, and mountain is triangle. So remember the simple logic: expiration looks like a triangle and inspiration looks like a face, which is semicircle. So you'll not forget that normal graph, the expiration look like a triangle and the face look like a semicircle. Okay. Just be here for some time if quality is the issue, because I'll be shifting to studio very soon. So after break, I'll shift to main studio. So just bear the quality. One second. Chalo, okay. I'm telling you now. See, understand, okay? When the person is peak flow, the larger airway are open. But what happens when the air come from smaller airway, they get compressed by high thoracic pressure. So what happens? They get compressed. So the speed will fall. So that's why you see a sharp fall in speed. But there's a okay. It's not pause. I was just checking my phone. Okay. So fall in flow rate. So fall in flow rate due to compression of smaller airways by high intensity. So by which pressure? High intrathoracic pressure. Okay, so high intrathoracic pressure cause what? It cause a yes fall in what thing? Flow rate. So it cause a fall in the flow rate. Okay. So therefore, what happened? The flow rate decline very. That is why we get not a smooth but a rapid decline. So it should be like this now. What happens? It was like this. So that's why from a smooth curve we get a very sharp curve. So are you now clear, Rohan? That's why you get a triangle, not a semicircle, not a semicircle. Okay. So let's see what happens in the diseases. So let's start now. So first is if there is obstruction, you will get the following. This is normal. This is normal. So let's start. First is look at this graph. What is the problem you see in this graph? What is the problem? It is having what problem? Inspiration, expiration, both. What is the problem in this graph? Inspiration, expiration, and both. So clear? Tell me. So yes, it is poor inspiration. This is normal. It look poor. So that's why it's a variable obstruction and most likely variable extra thoracic. So it's a V2. Okay, so yes, it's an inspiration problem, V2. Then look at this graph. What is the problem in this graph? Tell me the problem. So are you clear? So is it V2, Y2? So it is V2 and Y2 we are having in this case, okay? And this V2, Y2 are what we have seen. So this one is looking something different. So what is the graph? Tell me. Fixed both. So that's why it's a fixed obstruction. So ideally it should be like this. So this is a fixed, very good. So it is a fixed airway. Are you clear? So it is a type of fixed obstruction. Are you clear? Fixed obstruction. Okay. And finally, look at this one. Here, what is poor? Inspiration, expiration. Okay. So yes, it is extra thoracic. So its problem is what? So it's a poor expiration, mainly in the middle. Mainly the middle point is very affected. This is affected, but this is gone almost. So that's why it's a poor expiration. So it's most likely a small airway obstruction, intrathoracic, V2. Very small airway. So it's most likely a emphysema, COPD. So it's a emphysema, COPD, COPD. So usually it is almost normal, but this is what? This is yes, not restriction. Restriction what happens? The flow is normal. Restriction flow is not the problem. The vital capacity is the problem. So here there is a poor VC, but almost normal FeV1 percentage and flow rates. COPD, yes, true. It is a extra thoracic, no. Fixed, no. So that's why it is answer is B. Yes, expiration is poor. Okay, fine. Now question number 13. What does the slope A represent? So we are seeing this question. Slope A represents. Okay. So this is again a volume pressure curve. So remember volume pressure is compliance curves. Okay. So volume pressure is compliance. Delta V by delta V. That is change in volume by change in pressure. So PV loop, we use the PV loop again. That was flow, this is PV loop. Okay. Restrictive, the graph will be very narrow. So restrictive, narrow graph. Narrow graph like this. Can you see? So this is normal. So this has normal VC. So this is a case. I told you for V2, the graph for V2 would be the, I've discussed this one now. This is V2. No? this is veto. Okay, Devansh, for veto, this is graph. Okay, this is graph for veto. Okay, poor respiration. Okay, okay, Devansh. So you'll see a very poor. It will be like this. Okay, so this is veto. Can you see? Okay, now let's go. So what is the concept of compliance? So compliance is your so this gives the vital capacity. Volume is vital capacity. Okay. COVID, again, COVID will be a type of what? It's a type of interstitial lung disease with collapse of lung. So you can also take it as a type of restrictive. So you'll get a graph which show mainly restrictive pattern. Okay, clear? And if there's a airway involvement, okay, which is less but can occur, you will see a obstructive pattern. Okay, so mostly you'll get a restrictive pattern. Okay, for COVID. Okay, sin narrow graph. See, if there's a severe airway obstruction, let's say there is a tumor, let's say the bronchogenic or a foreign, if one of the bronchus block, there will be no inspiration, no expiration. Severe obstruction. Like example, one bronchus completely blocked. So now no air can go out. So that will cause a very severe problem in this case. Are you clear? So very severe problem would be there. Okay. So we'll have a very that will cause a very severe problem. Are you clear? Okay, just bear 1 or 2 minutes. I will get another graph. Okay. And so if there's a very small lumen, air cannot come, cannot go. So that's why both are affected in this case. Okay, both are affected. Okay. Yes, it can be also. Okay. Okay, so let's do one. Okay, so I'll take a break now. Okay, I thought I'll take it at 30. I'll take a break now and we'll shift to the other studio. Okay, once it is available. So we'll take a 10-15 break. Okay, and then we'll same concept there. Okay, so we'll take a 10 to 15 minutes. Let's start. So this is the compliance curve. We are getting the compliance. And compliance, remember, is decrease in restrictive lung diseases, RLD, and increase in emphysema only. So that's why it is increase in emphysema and decrease in restrictive lung disease. So decrease in the restrictive lung diseases. Okay. It's not buffering, I think. It has started, I think. Any issue, please inform. I'll start the class now. So should I start? It was going from my end. Okay, I can see it on the studio. Okay, it's fine. Okay. So therefore, the formula of compliance is given as delta V by delta P. So let's calculate. Let's take one value. So I am taking that value as 10. Or we can take 20 also. So let's compare normal. So it is almost equal to 6500 ml at 20 mm Hg. At which value? At 20 mm of mercury. So let's calculate the compliance. So it would be around 325 ml per centimeter. Okay. Whereas in B, what is the value? It is, let's say, 2.5. it is 2500 ml for a pressure of 20, that give 125 ml per centimeter. And in the A, we get almost 7500. So it is 7500 by 20, and that is how much? Okay, that's close to 375. Okay, so we can see that if you take this as normal 325, obviously 375 is higher, so it is higher. Okay, is it? It's 550. Sorry, you are right, it's 550. So it should be, yes, 375, 275. So if 275 is normal, A is higher and B is low compliance. So that means in low compliance, the graph will shift to the left and lower side. So that is most likely example RLD, and this is emphysema. So which one is emphysema? So obviously emphysema is graph number A. So A is emphysema. I hope it's clear. So A is the emphysema curve. So let's see the question. Bronchitis, the compliance can be normal. So it can be normal compliance. RLD, there is a decreased compliance. Emphysema, there is a increase. Single lung, if there is decreased lung volume, the compliance decrease because two lungs have more volume to stretch. So again, decreased compliance. Why? More the lung volume, more the compliance. More the compliance. So therefore, the answer would be yes. Obviously, we are going to take the answer as our option number C. C is the right answer. Okay. Next question. 45-year-old men inhale as much air as possible and then expired with maximum effort. So now let's start. So this is first question, the same flow volume curve that I have taught you, discuss already. This is actually the flow volume, and I told you this give you vital capacity. If you remember, it gives you the vital capacity. So let's start from the beginning. First, it is the point that is 5.5. This is TLC. So 5.5 liter is total lung capacity. Okay, and he start to expire from here, and he expired till 1. So this is residual volume. This is your VC. This is your VC. Okay, and you know that TLC is VC plus RV. So what must be the VC? It is TLC minus RV is VC, and you know RV is 1 liter here, 1 liter. So what is the VC? Obviously it is 5.5 minus 1, that is 4.5 liter. So that give you a value of 4.5 liter. Okay, and I told you in restrictive the value will decrease, the VC will decrease. So answer is C, 4.5. There's no doubt in that. So answer is C, 4.5. Okay, okay, and you know the formula. Let me revise it for you. So the flow volume curves, this is the spirometry curve. This is tidal volume, this is TV, this is IRV, this is ERV. Okay, this is maximum inspiration, this is maximum expiration. Now this value is called as vital capacity. So this value is given the name of vital capacity. Okay, so this is, and if you add all, even this ear which is not coming on this ear, this is residual volume. It is not coming even after forceful. So this become your TLC. So it's TLC, total lung capacity. So TLC is total lung capacity. Okay. RV is air not coming even after forceful expiration. Okay. Okay. So what is the answer in this case? So the answer is obviously C. Okay. Next question. Untrained person going to higher altitude for training can have maximum arc limit. So first let's see what is the problem in this case and we'll see the questions. Okay. So first understand what happens in high altitudes, right? High altitude, there is decrease PO2, okay, because of due to lower atmospheric pressure. Now because there is a lower oxygen level because of atmospheric pressure which is being low, what will happen in this case? So what happens in this case is it causes hypoxic hypoxia. This hypoxic hypoxia then causes what? Hyperventilation because of chemoreceptors. So hyperventilation due to chemoreceptors and also cause pulmonary vasoconstriction. So remember, hypoxia cause pulmonary vasoconstriction, okay, via potassium channels. Okay, so there are potassium channels which are oxygen sensitive. So as there is a decreased blood flow, etc., they will cause constriction. Now because of constriction, there is what? There is increased pulmonary vascular resistance. Which causes ischemia. Then it causes, yes, release of various inflammatory mediator because of ischemia, which causes increased capillary, and it can cause pulmonary hypertension also, which is very dangerous, and capillary permeability. And this causes pulmonary edema. Pulmonary. And this pulmonary edema is the most common cause of death in mountain sickness. MCC of death in mountain sickness. So what is the most common cause of death in mountain sickness? The answer is, it is our, yes, pulmonary edema. Okay, so it is the pulmonary edema which is the most common cause. Okay. So done. So are you clear? Now this hyperventilation causes CO2 washout. It has two changes. One, it causes respiratory alkalosis. So CO2 washout causes a respiratory alkalosis. So there is a respiratory alkalosis, and there is also what? And to correct, we can give treatment is, we can give acetazolamide. Acetazolamide. Okay. And for pulmonary edema, the treatment is mainly steroids. And for hypertension, the treatment is we give the vasodilators, especially CCBs, or we can use the sartans. Okay, that is the angiotensin receptor antagonist. Okay, we can even use nitrates. Okay, and second, it causes what? CO2. So that causes apnea. Why? Because when there is high CO2, there is a hyperventilation. Low CO2 causes apnea, and this apnea is followed by hyperventilation. And again apnea. So this is called as Kine-Stokes respiration. Okay, Kine-Stokes breathing. Okay, in fact it is given as one of the options here. Can you see this? So this is the Kienstokes breathing. Okay, clear? The E here. So it looks like this: hyperventilation, apnea, hyperventilation, apnea, hyperventilation. So there are periods of what? Hyperventilation and apnea. So there are hyperventilations and apnea. Okay, chalo. Now let's solve this question itself. So what is this pattern of breathing? So this is called as Kienstokes breathing. Okay, Kussmaul's is a hyperventilation. There is no apnea there. Hyper, because there's a high CO2 and high H plus. Hyperventilation in diabetic ketoacidosis. So there is no hyperventilation there. Okay. Paradoxical, what happens in this case? The chest move inward in inspiration. Chest move inwards in inspiration. That is paradoxical breathing. So this is the paradoxical breathing. Okay, clear? Example is, yes, flail chest. Biot's is irregular with apnea spells. So irregular with apnea spell like this. This is Biot's and is seen basically in uremia. Previous question, I'm not been there. Okay, clear? So Robin, I have to give the answer of 15. I'm just giving this question because it's already been discussed. Okay, I'll give the answer in a minute. Okay, so uremia and also the brainstem lesions. Brainstem lesion. So Biot's I have already drawn. Now this is Biot's. Irregular. Biot's is irregular. Okay, you cannot make a graph. Why? Because in this case, if normal graph file as this, okay, now it will be reverse. It will be like this. Are you clear? So there's no point drawing it. So in this case, normally inspiration we make the graph going upward, but in this case the reverse occur. The chest move inward in inspiration. Okay, so that is the graph. Okay, Robin. And in Kienstoke, it's already given Kienstokes. This is the Kienstokes. This is Kienstokes. This is the Kienstokes. Okay, this is hyperventilation only. This is hyperventilation. Okay, which previous? I have not yet given the answer of question number 14. 14 I said now. This is he starting the forceful. So he expired the air. 15 I am not yet given the answer. Please have patience. Okay, I said na 15 I'll explain. Okay, I just went to this graph and I explained this graph because already given as a question number 16. So 15 I am just about to come, that how do you give acclimatization in a person going to high altitude. It's about to come. Okay, have patience. So this is what 5.5 is what it is, the total lung capacity. His lungs are full of air. It is the point of maximum inspiration. And now he start to expire. This is expiration. So now as he expire, air will keep coming. So how much air came? From 5.5, 1 liter air is the only air left. So RV is left. So how much air came? 4.5. You can see this, na? So what is the value inside the graph from 1 liter to 5.5? It is 4.5. So VC is 4.5 liter. Are you clear now? Done? Question number 15, I will come. Please wait. 16, I have already drawn the graphs. Irregular breathing with apnea spells like this. Okay, not all respiratory alkalosis will be Kienstokes because there must be a hypoxia as well. Are you clear now? So there is the hypoxia which is there. If there is no hypoxia, it will just cause what? Lots of apnea and hypoventilation. Are you clear now? So it just causes hypoventilation. Okay, clear? So if there is this, okay, alkalosis, the patient will have hyperventilation. Okay, clear? Okay, Rohan. So not all case of respiratory alkalosis you will see Kienstrokes breathing. Okay, Kienstrokes is seen mainly with hypoxia or poor blood flow to the chemoreceptor. So they cause the hyperventilation. CO2 washout causes the apnea. Okay, so I hope you have understood. So tell me, what is this graph? This is biots. This one Kienstrokes. Okay, now getting hyperventilation is Kussmaul. So I think now it's clear to all of you. So biots, Kienstroke, Kussmauls. Okay, clear? This is normal. This is normal tidal breathing. This is normal biots, Kienstrokes, Kussmauls. Okay. Okay. Let's come to that question number 15th. Okay. So if you want to survive at high altitude, what do we need? We need acclimatization. Okay. So what is acclimatization? Is the ability of the body to adapt to what? High altitude, yes, breathing. Okay. So we use the acclimatization. The main basis is, yes, it is chronic hypoxia is the main stimulus. Chronic hypoxia help. Okay. Kienstroke is not seen in uremia. Okay, clear? Fine. Yes, it can be called as cluster. Yes, Robin. But remember, Kienstroke is not seen in uremia. Uremia you see basically biots. So uremia is biots. Okay. Heart failure we see Kienstrokes again. Okay. Also seen in heart failure. Congestive heart failure also. Okay. Fine. So let's start. So chronic hypoxia help. How? I'll tell you. Okay. So first question is it will cause HIF to increase. What is HIF? Hypoxia inducible factors. Yes, we can see. Okay. So what is HIF? They are hypoxia inducible factors. Okay. Next, what they do? They are basically transcriptional factors. They increase mRNA from the nucleus, and that, so there are transcriptional factors. Okay. Now, this mRNA then create proteins. So it causes increased proteins. Especially two proteins are very special. One is VEGF and EPO. What is EPO? Erythropoietin. Erythropoietin, okay, and VEGF, okay. Now it causes increased RBC production, and this RBC create increased oxygen carrying capacity. So that's why when this person breathe, even a small breath can give him tremendous oxygen carrying capacity. So there is a what? Increase in the O2 carrying capacity. Are you clear? Now VEGF. So when there is a VEGF, what happens? It causes increased vessel formation. Increased vessels cause increased blood flow to tissues, and These two factors, and also plus also there is what, increase chest capacity. So these factors will correct hypoxia. Okay. Also there is a increase cardiac output, also increase respiratory lung volumes and capacity. So that's why this person can take much deeper breath and able to expand the lungs much more. So that is why he's able to enhance his capability more. So that is the case. So question is what the person should do. If he do no physical activity, the oxygen demand is not increase much. So that's why the hypoxia will be not very effective. So if we do increase physical activity, severe workload, that cause increase oxygen demand, acute increase, and that cause severe hypoxia can cause pulmonary edema. So that is why for better acclimatization, what we do, we will try to increase the duration of exercise. We will try to increase the duration of exercise. So what we try, increase the duration of exercise. So we'll try to increase the duration of the exercise. Okay. So increase, but decrease the load. So that's why increased duration will create a chronic hypoxia. Are you clear? But decrease the load, because that can increase oxygen demand and precipitate severe acute hypoxia, and that will cause what? Pulmonary edema and cause mountain sickness. Okay, and that will cause mountain sickness. It's like what, when you go to a desert, don't open a water park there, because there's no water in that. So that's why you should try to have reduce the oxygen demand, not increase it. Okay, so what the answer in this case? So answer is chronic increase in the load, not acute. So why the load is low? Because to keep the workload low, so that the demand is not increased very sharp, but increase the duration, so that chronic. So load should be there. So exercise, let me say, exercise will create hypoxia, and a longer duration create a chronic hypoxia, but load should be decreased. Okay, better we do isotonic. Isometric cause higher demand, so we prefer isotonic, because isometric are not good for blood flow. They keep the muscle compressed. So isotonic is better. Okay, for the answer of this question, untrained person can have maximum. So decrease the load and increase the duration. Rest all are wrong. Okay, so we should decrease the load, not increase, and duration should be increase. Okay, question number 16 done. 17. A person goes to the COPD. He is having, so is a classical case of what? COPD with pulmonary edema, peripheral edema. That means there is a heart failure also. There is a heart failure, that is cor pulmonale. So is most likely having a cor pulmonale also. Now he is hyperventilating, so obviously that will cause what? That will cause the alveolar level to be almost normal. So that's why this hyperventilation should create a normal, or rather a higher, so create normal or rather a increase PaO2. So let's say it is around 100 or above 100. So that is why it is close to 100 mmHg is normal. So might be even more. So this is normal. So it will create almost 100. Okay, but because of the damage to the alveoli and the pulmonary capillary, there is a diffusion defect, and that's why oxygen will still come less. Okay, but still hypoxia, that is decrease PaO2 due to defect in alveoli and pulmonary capillary. So there's a defect in the alveoli and the pulmonary capillary. So that is a diffusion disorder. So there is a diffusion disorder. So that is why there is a diffusion disorder which is taken. Nikhil, I told na, if there is a decreased load, hypoxia will not be severe. Like example, if I go to high altitude and start doing exercise, I take dumbbells and do, I'll become Arnold here. I will not become Arnold. I'll die there. Why? Because that's called sudden increase in the oxygen demand and severe hypoxia occur. And severe hypoxia cause severe pulmonary vasoconstriction, and that can cause pulmonary edema and death. So that is why we need to decrease the load, not increase the load. Okay, we cannot make it zero. Zero load is bad because that will again decrease the circulation. So that's why we need normal load, not a high load. Okay. Okay. So therefore, what is happening? There is a hypoxic. So therefore, let's take it is 100. So what is the AA gradient? Okay. And with the marker, there's an increase AA gradient. So in diffusion disorder, what increases? AA, and is also having a respiratory alkalosis. So it's a classical case of emphysema. So let's calculate his AA gradient. So PaO2 minus PaO2 will give you AA gradient. So that's we take 100. We are taking 100. We are not given, but we assume it will be normal. Minus, let's say how much? 60. So that will be around 40. Around 40. Okay. And if you hyperventilate, might be more or more. So if you take it 100 or 110 minus 60, it will be 50. Now it cannot be 150 because atmospheric air itself is 150. So it cannot be 150. Why? Because the atmospheric air is 150. So that is why you can have 40. So best answer would be 50. Okay. 10 and 20 indicate normal. 10, 20 is normal. And here there is not normal but increase AA gradient. It is increase, not normal. That's why I will suggest go with option number D. Okay. So D is the answer. Now, what happens when there is a efferent arteriolar constriction? So let's do this question. So first, let's say this is the afferent. These are glomerular capillaries. This is efferent, okay? And this is your Bowman's capsule. So first, the amount filtered. This is GFR. Okay, this is afferent, this is efferent. So let's say if you constrict the efferent, I'll first start with afferent. So if I constrict the afferent, so if I constrict afferent, so this is a renal blood flow. Sorry. This is okay. So if I do a afferent constriction, obviously there is an increased resistance. And example is alpha 1, which I discussed already, norepinephrine, epinephrine. Okay, so it causes a decrease renal blood flow. So renal blood flow is going to decrease in this case. Okay, then not just the renal blood flow decrease, it also cause a decreased GFR. Also cause a decrease in the GFR also. Okay, so what happens to GFR? It will also decrease. So GFR will decrease. Next question. Also, it will lead to a decreased urine output. See, diffusion is movement through the alveoli. So if alveoli is damaged, the oxygen cannot cross from lungs, alveoli to the blood. So because of damage to the alveoli, you know this, let me show you this photo. It might clear your doubt. So let's have a look at this image. See, this is what we use for emphysema. That is the MMRC grading or this COPD assessment test. Okay. So what is happening in COPD is, understand, there is smoking. This smoking will cause radicals, also activation of elastase enzyme. They will then cause damage to the elastin protein and causes the alveoli to be damaged. As the alveoli get damaged, their membranes will reduce in the area and causes reduced diffusion
of the oxygen from lungs to blood. Also, there is a damage to the pulmonary capillary. So therefore, net result is what? There is a very severe, can you see this? Very problematic diffusion of the gases, okay? And that's why very important, there is insufficiency in the terminal end, and there is always a hyperventilation to compensate for that, okay? Fine. Okay, I told in question 17, okay, I told you the patient has a damage. Pink, I told you, na, he is having a damage to the alveoli. How can oxygen go from lungs to the blood if the alveoli is damaged? Can you get this question? So if alveoli is damaged, oxygen should and not able to cross. So therefore oxygen failed to cross. This is what is called as diffusion disorder, because the alveoli are damaged because of increased inflammatory changes, production of radicals, and the WBCs, okay? So that's why diffusion defect is there, okay? Okay. So if there is a efferent arteriolar constriction, the blood that is coming will reduce, okay? And that is why there is oliguria. In shock, example, shock. So oliguria occur in shock, okay? Now if you constrict the efferent arteriole, efferent constriction, example is angiotensin 2, okay? Angiotensin 2, what will happen? So first is, since the blood will accumulate, the blood is going to accumulate in the glomerulus, so that will create a traffic jam and the flow will again reduce, so it causes a blood accumulation in glomerular capillaries. And if blood accumulate in glomerular capillary, that is obviously going to what? Decrease renal blood flow. So it causes a decrease renal blood flow, but because of this higher, there's an increased hydrostatic pressure. And blood flow is plasma flow also. So blood flow, you can use the word RPF also, because blood is actually plasma plus RBC. So decrease hydrostatic pressure. Decrease which pressure? Hydrostatic pressure. So which pressure it is? Hydrostatic pressure. Okay. And the result is what? This causes increased GFR. So therefore it is a reverse change. RBF will decrease but GFR will increase. What is the right answer in question number 18? So you will see a increase in the GFR but decrease in this RBF. D is the answer. Okay. Next question, let me explain this question, that what is the concept. So first understand that clearance is equal to GFR if only filtration occurred. Only filtration occurred. Example, inulin. So that's why inulin clearance is equal to GFR, that is 125 ml per minute. Are you clear? Then if you secrete, then the clearance increase because you are able to clear more substance. So now it is more than. See Daniel, we are talking about the about the acute change here, okay? Long term everything will decrease. Even in the afferent, long term what happened? Too much blood will come and that cause too much urine, that cause a decreased blood volume. Decreased blood volume will decrease renal blood flow and eventually GFR will decrease here also. So nothing is going to increase. Eventually your BP will decrease, heart rate will decrease, and we all will die. So eventual result is end everything. So efferent constriction, again, eventually, yes, initially, later it will fall. Then none of the answer will be. Then I'll only write one question, that is this one. So are you clear? So that's why when we make question on the basis of what is the most logical first response, and that is increase GFR initially, later fall. Clear? So later it will fall. Okay, fine. So therefore, please select the answer based on the immediate response. Okay, not the long-term responses. Okay. Now, let's say, so clearance is more than GFR if secretion also occur. If filtration plus secretion. Okay, filtration plus secretion. Okay, and example is, and if 100% secreted, 100% secretion, then clearance is equal to RPF around 625 to 695 ml per minute. So 625 to which value? 695 ml per minute is the value. Okay, so what is the value now? 625 to 695. Okay, so what is the value? 625 to 695. So 625 to 695 ml is the value in this case. Okay, now question is, but there is a limit of secretion, there is a limit of secretion. There is limit of secretion, and what is the example? Example is PAH. What is that? Para amino hippuric acid. So what is pH? PAH is para amino hippuric acid. So what is pH? It's para amino hippuric acid. But there's a limit to secretion, limit of secretion. Okay, so at very high concentration, the secretion will not be able to keep up with the increase in plasma concentration. So that is why at very high concentration, like above threshold, you cannot secrete 100%. So that is why at very high plasma concentration, we can't secrete all pH, so that is less than 100% secretion. So clearance will fall and we get actual RPF or lower. So we get a lower, but this low is not because of what? Because of problem in the plasma flow. Problem is your method is having an error and we get a lower clearance. Hence a false low RPF. So that is why if you use PAH for RPF estimation, so we use it for which estimation? RPF estimation. So we use it for which purpose? RPF estimation. But problem is, if you are using what thing? If you are using a very high amount, then it will create a problem. Okay, so then it will give a right or a long value. So then it will give a very wrong value. I hope it's clear. So it will give a very wrong value. Okay, so clear? Okay. So now therefore we should use only the required level, not very high level, not very high level. So the limit of what? Limit of secretion. This is the limit of secretion. Now comes the second question. What is the second question? We will see or have. If reabsorption occur, so the answer of this question is done already. Then again people answer why you're moving forward. So the answer is, if you give a very high amount, you will get a false low value. Why? Because there's a limit to secretion. At very high concentration, you can't secrete completely. So the reason is what? There is limit, a limit of secretion called as Tmax. So that's why if you go above the value, you can't secrete all, so clearance will fall. So can't secrete 100%. So that is why you get a false low. So answer is B. Answer is B. Now we are continuing with this graph. So I'm explaining this graph. So as you can see in this graph, this green has initially clearance of 625, but above 10 milligram percent, that is called as the threshold. This is 10 is threshold. Renal threshold. So what happens? The clearance will decrease. So there is a decrease in the clearance, and that's why clearance, this is most likely a pH. So that is why pH clearance will fall. Okay, so it will keep falling. Okay, whereas a substance which is reabsorbed has a lower clearance. Okay, so glucose is 100% reabsorbed. So glucose is what reabsorbed? 100% reabsorbed. So glucose is what reabsorbed? 100% reabsorbed. If the glucose is 100% reabsorbed, what is the result? Result is nothing is clear. So clearance is equal to 0. Is 0. Okay. So that's why glucose is 0 clearance. Okay. Clear? Because all is reabsorbed. But again same, but again there is limit. There's limit. So at very high concentration, very high concentration of glucose, so at very high concentration, we can't absorb all. We can't absorb all. So tubules fail to reabsorb all the glucose. So tubule will fail to reabsorb all the glucose, hence glycosuria occur. And clearance is now non-zero. So clearance is what? Clearance is non-zero. So what is the clearance now? Is it 0? No. So clearance is now non-zero value. I hope it's clear. So now the clearance is a non-zero value. Okay. So clearance is non-zero. Okay. And what that value called as? It is called as renal threshold. So RT, renal threshold. So what is the renal threshold for glucose? Is around 180 to 200 milligram percent. So if glucose concentration rise above 180 to 200, glycosuria will occur and we will see the glycosuria taking place. Are you clear? So glycosuria will take place. Okay. So are you clear? So are you clear? Okay. So let's see this. Here there is zero clearance. But the moment you cross this value, this is what? 200. This is renal threshold again. Okay, RT. So at this, for X is glucose. So remember, it will now start appearing. So now the clearance is increasing. So now the clearance is increasing, and Z, the clearance always remain 125. So what is this substance? This is inulin. So inulin is only filtered, neither secreted nor reabsorbed. So that's why inulin clearance remain constant. Why? It is only filtered. So it doesn't matter it is high or low. It will always be filtered at the same rate 125. So clearance remains same. So clearance will remain the same always and always. I hope it's clear. So clearance is what? High, low or same? It is always and always the same. Chalo. Chalo. So let's start now. Okay. So what is the answer? So obviously they're asking which substance is Z. So Z is inulin. Glucose is X. PaH is Y. Urea is not shown, but urea will behave very similar to what? Glucose. Okay. So it's like glucose. So starting clearance is how much? It is 70 ml per minute. So it will be like this. I'll use a blue pen. So it will be close to 70 like this. And then it will start to rise. Okay, start to rise. This is urea. Okay, this is urea. Okay, urea. Okay, so urea will be 70 in the beginning and then start to rise and become almost 125. Okay, so urea I've made this. Okay, this is urea. Okay, so all which are secreted will fall, all who are reabsorbed will rise up. Okay, so again increase clearance. Are you clear? So done.